Hello and welcome to the Inland Empire Healthy Living Virtual Expo hosted by the Press Enterprise, Inland Valley Daily Bulletin, The Sun, and Redlands Daily Facts. I'm Julie Corlett from the Southern California News Group. Thank you for joining us today. Our session is sponsored by SI Bone, and the topic is low back pain's missing piece, the SI joint. I would love to take this opportunity to welcome Danielle Ruggiero and Nicole Gossett. They'll take over now. Thank you and welcome.
Thank you so much, Julie. Hello, everyone. On behalf of SI Bone, we'd like to thank you so much for joining us today. We will be discussing low back pain's missing piece, diagnosing the sacroiliac joint. Like Julie said, my name is Nicole Gossett, and before I turn the presentation over to Danielle, I wanted to invite your engagement in the discussion today. We're going to ask you to submit your questions, and to do so, please use the Q&A feature at the bottom of your screen and type your inquiries directly in to the questions field. We will also try to address all of the comments and questions that you have at the end of the discussion as time permits. Another thing that we'll do is we'll have periodic poll questions that we'll launch throughout the webinar to better understand you as an audience, the duration of your pain, and what treatment options you've tried. So without further ado, I'll turn it over to Danielle to lead our session this morning.
Thank you, Nicole. Thank you, Julie. And good morning, everyone. Thank you so much for listening in today. I've done lots of talks in the past, but I have to admit this is my first virtual patient seminar. I'm going to plan to speak today for about 20 to 30 minutes, and then we'll turn it over for some questions, because I do believe that that really tends to be one of the most valuable aspects of doing these talks, is to get to hear feedback and try to answer whatever questions I can for you. So today we're going to be discussing sacroiliac pathology. I do have some slides, but I'm going to try to keep this very informal, like I said, and we'll try to make it as interactive as we can by doing polling questions and questions at the end. So during the last 8 years or so, I've been treating more and more patients with sacroiliac dysfunction. It's very commonly underdiagnosed, but it's much more common than most people actually realize. We now have a great deal of solutions for this joint, so I wanted to spend some time really discussing this dysfunction of the SI joint, as well as treatment options and their efficacy. Okay, so a little bit about myself. Living in New York City during the attacks of September 11th really played a fundamental role in the trajectory of my career path. Despite being accepted into pre-medical program down in sunny Florida, I decided to stay in New York and attend PA school because I knew that it would really allow me to get to work sooner as a vital medical practitioner in what was really an overwhelmed healthcare system in New York City. Patients really needed care, and I wanted to be on that front line. So many city workers who had reported to duty on that, that fateful day had debilitating illnesses and injuries. So it was my honor to help them heal and help the city recover. I've spent years working in the trauma bays, ICUs, operating rooms, and some of New York City's busiest hospitals. And treating patients with spinal disorders and traumatic injuries became my passion. And ultimately, this is what I wound up specializing in. So before we get started into our talk today, I wanted to ask our first question to the audience. So question number 1, prior to today's session or this talk, were you familiar with the term sacroiliac or SI joint, as we like to refer it? Yes or no? You can go ahead and click the answer on your screen there. Okay. All right. So just a little bit of an overview here as we start getting into this talk now. We're going to discuss several things. So the first thing we really want to get into is low back pain and a little bit about our spinal anatomy. And before we move into the prevalence of SI joint dysfunction or sacroiliac joint dysfunction, what is the sacroiliac joint? Why is it a pain generator? And why is it sometimes misdiagnosed in this whole algorithm of low back pain? We're going to talk about some common causes and symptoms and what this looks like to you on a daily basis. And finally, we'll talk about how we go about diagnosing sacroiliac joint problems and then how we treat them, ranging from the least invasive to surgical options. And again, at the end, we will have plenty of time to answer any of your questions. So as far as impact of low back pain, we know that this is a huge drain on our lives, on our economy. And if you're here today, there's a good chance that you may too have experienced back pain and want to learn more. So you're not alone. Low back pain accounts for about 15 million office visits annually. It's second only to the common cold in reasons for visiting a doctor, although unfortunately this year that statistic may be a little bit different due to the coronavirus pandemic, unfortunately. But as far as low back pain goes, this is rated the fifth most common reason for hospital admission in this country, with annual costs of about $86 billion. And it's estimated that every American during the duration of their lifetime will have at least one bout of low back pain. Okay, so now we're going to move into poll question number 2. So if in fact you do have low back pain, how long have you experienced low back pain? And you can go ahead and choose the answer that you'd like here. So less than 6 months, 6 months to 1 year, 1 to 3 years, or more than 3 years. Okay.
Danielle, let's give Julie an opportunity to share the audience participation so that we
did it
can
not come up there? Okay. Let's go back there. Oh, there we go. Great.
Perfect.
All right.
Thank you so much. So Danielle, based on what you see and have seen in private practice when you've been seeing patients on a daily basis, is this typical with what you saw in your neurosurgery practice, where patients have been in pain for, based on this, it looks like about half the people have experienced this back pain for more than 3 years.
Absolutely. Back pain, it's something that a lot of us unfortunately live with. And, whether it's just something that we've grown used to dealing with, or something that we don't necessarily want to have treated, or, something that we just, unfortunately, due to an accident or any type of traumatic injury, there are many reasons for why people tend to suffer with low back pain, or maybe treatment options haven't worked previously. So it is interesting, and it's unfortunate because we do have really good solutions for a lot of these causes of back pain. And what's really interesting about the SI joint is that it is one of the most, again, underdiagnosed pathologies out there. And a lot of practitioners still to this day aren't diagnosing it as frequently as they should be, because it is a little bit tricky to diagnose. And we'll get into some of that. So, for those of you out there with low back pain, I'm sorry. And I hope that this presentation really does kind of shed some light on, on what may be another cause of your back pain.
Absolutely. And so much of the time, it will take, because there can be overlapping pain patterns, and it really takes honing in on the right diagnosis. And I know that you're going to cover that in terms of the SI joint and how it's differentiated. So without further ado, we'll let you get into it. Thanks, Danielle.
Yeah, no, thank you. And thank you all for polling. It's nice to be able to have, even though I can't see all of your beautiful faces, at least I know you're there. And so hopefully we'll try to make this as interactive as we can. So let's move on now and sort of get into anatomy. And I am not quizzing any of you on this, so don't worry. But basically, we're all probably a little bit familiar with the anatomy of our spine. We have 24 vertebrae in most people. Some people have slight variances. The cervical and lumbar vertebrae are generally more mobile, meaning they move around a little bit more. And so because of that increased movement in those two areas, the lumbar and cervical spine tend to be where we see more of the degenerative problems in one's lifetime. The thoracic spine, which is really sort of that middle part of your spine there, that's stabilized by the rib cage in the front of your body and in the side of your body. So it's relatively immobile, meaning it does not move as much. So we don't see as many degenerative conditions in that portion of the spine. And I'd like to refer to the discs in our spine as jelly-filled donuts. I know it's a food analogy, so forgive me. I just think it's a nice way sometimes to explain these problems. So the discs are soft and spongy, so it should act like a shock absorber for the spine itself, the bones of the spine. You know, at each level of the spine, we have nerves that will exit out from the spinal cord and can become compressed or pinched if that jelly or disc material has bulged or herniated out from the annulus, which is that outer layer. So you may have heard of sciatica. This is basically what that describes, a pinched nerve due to the jelly sort of leaking out of the disc. And the lowest part of our spine, we have our sacrum. So this is what connects the pelvis at the sacroiliac joint. And from here on out, you may hear me refer to the sacroiliac joint as the SIJ, just to make it easier. But I wanted to give you just a little bit of an overview there so you have a kind of a basic knowledge. Okay, so we're going to get into a little animation video here. Let's make sure this is working for you. This is a pretty cool little clip we have. Okay, so you can see here, our body has two sacroiliac joints. One is on either side of the sacrum, and this joint will connect the spine to the lower part of the body at the pelvis, specifically joining the sacrum to the iliac bones. And just like the discs are individual shock absorbers at each level of the spine, the sacroiliac joint protects the spine from forces coming from the upper parts of the body as well as the lower parts of the body. So think of a high-speed runner who's impacting the ground with her foot. The SIJ is what's going to help absorb that shock and reduce the stress on the upper body. So imagine how much of our body uses this joint every day, walking, standing, climbing stairs. All of these normal functions of daily life really are affected by this joint. And, you know, because of that, because of this repetitive stress that we have on the joint, the body has developed an incredible system of ligaments and muscles which help to envelop and support it. This muscular and ligamentous network of stability also helps to prevent the SIJ from moving. So it's not to say that the sacroiliac joint doesn't move at all. In females, it has a very small degree of motion, about 4 degrees. Males is a little bit less than that, about 2 degrees at most. And the reason why females have a little bit more is just for the simple fact that females do need to birth their children. And so when they do that, this joint does actually loosen a little bit to allow for that, that natural process to happen. Okay, so let's move on. Okay, now as far as prevalence of sacroiliac joint disease, and this is really what's an incredible statistic here, and I think a lot of people really, again, you know, are amazed when they see these numbers here. So, you know, about 10 years ago, when I first started diagnosing sacroiliac joint dysfunction in our practice, it was hard for me to imagine that up to 15 to 30% of my patients actually had this because I wasn't really familiar with it and I wasn't diagnosing it prior to that point. And so, you know, studies had started coming out in 2009, 2010, and people really started looking at this joint as a significant reason for having low back pain. And so you can see across these studies here, we range anywhere, again, from about 15% up to 30% of patients who present to offices, whether it be your primary medical doctor, whether it be your PA or nurse practitioner or emergency room. If you're coming in with a complaint of low back pain, there is a 30% chance, up to a 30% chance that you might actually have pain which is originating from that sacroiliac joint. And what we see in this pie graph on the right side here, so this number, as far as prevalence, is even higher if you had any history of lumbar fusion. So even if you've only had a 1-level lumbar fusion, that can give you up to 43% of a chance for developing symptomatic or painful sacroiliac joint dysfunction after the fusion. And this is something that we really began to see in our practice back in New York, any patient who had come in with lumbar fusion, you know, whether it be 6 months to 5 years after their surgery, you know, it was really frustrating because a lot of these patients were having a hard time. They didn't feel like they were being taken seriously. You know, a lot of times they wound up just seeking pain management help, when all along there really was a problem with this SI joint that we now know we can fix and we can treat very well. So we're you know, really proud to have the capabilities of being able to address and treat this joint. Okay, so as far as causes of sacroiliac joint dysfunction, you know, we have degenerative causes, which, like I just spoke about, you know, prior lumbar fusion, but we also have traumatic causes. So if you or anyone you know has been in a car accident, pregnancy and childbirth, falling, lifting injuries, repetitive injuries, all of these things can damage and cause sacroiliac joint dysfunction. Okay. And so as far as the symptoms, and this is where it gets a little bit tricky, because if you look at this diagram here on the right-hand side, you'll see sort of a black X marcation down the back of the leg there. And on the other one, you see some X's into the groin there. So this is a very common presentation or what a patient may be presenting to the practice complaining of. And if you've ever heard of sciatica or, you know, lumbar radiculopathy or pinched nerve, this pain pattern looks almost identical. And so for those practitioners out there who are not specifically looking for sacroiliac joint dysfunction, it may be easy to miss the SI joint as a pain generator because, again, there's such a significant overlap in symptoms. You can have pain starting, you know, right to the side of the lower part of the lumbar spine, to the buttock, to the back of the thigh. It can go all the way down into the calf, sometimes to the side of the calf. And again, sometimes we'll see these pain symptoms in the groin as well. So again, it can be a little bit tricky for practitioners to differentiate between sacroiliac joint dysfunction versus lumbar spine problem versus a hip problem. Okay. And as far as causing issues with day-to-day functionality, so we know that the sacroiliac joint, again, is a really vital part of our spine. It helps connect the spine to the lower part of the body, and it acts like that shock absorber. So because of that, it really does affect day-to-day activities. So a lot of the complaints that I would hear my patients come into the office saying, I can't sit for longer than a few minutes, I can't drive very far without pain, I've started carrying a pillow around with me to sit on. It hurts to go up or down stairs. I feel like I'm never able to sit in a comfortable seated position. And a lot of times in the office, these are the patients which I can tell right away because they're kind of sitting off to one side or to another side. Maybe they don't even want to sit in the exam room at all because it just hurts. Sometimes patients will say they need to hold on to a railing or they've started using a cane to get around. Sleeping is often affected, and a lot of patients will say that they feel restless, like they're not able to really get a good night's sleep because they're constantly tossing and turning and having pain laying on one side. And a lot of patients here in Southern California, which we now have the pleasure of being in, will actually say that walking on the beach is really difficult. And the reason for that would be because, you know, the sand is a little bit uneven. So as you're stepping on that sand, you know, you may be putting a little bit of pressure on that SI joint. So that's something here in Southern California that may be a trigger for SI joint pain. So we have a lot of reasons or a lot of different aspects of daily life that really can be affected by this diagnosis. Okay, now diagnosing sacroiliac joint dysfunction, again, it can be a little bit tricky because not all practitioners know what to look for. And even though it's always been a part of our anatomy, if you were to do a search in some medical literature from the early 1900s, you'd find quite a few articles actually talking about the SI joint and its significance in patients complaining of pain. You'd find chapters describing this debilitating disorder in some of the early medical textbooks. You know, so why then don't most of our clinicians consider this pathology in their differential diagnosis of low back pain? And one reason simply is the invention of the MRI machine, which is wonderful technology that we're very lucky to have. But over the course of the 1900s, many clinicians, orthopedic and neurosurgery and trauma surgeons and emergency physician practitioners, they began to look at this MRI as having a direct, case and point. So patient comes in with low back pain, we can get an MRI, and now we can directly see a cause for the pain. So the sacroiliac joint over time, it sort of fell out of favor because unfortunately, it does not really have an imaging modality. So we can't get an X-ray of the SI joint or an MRI of the SI joint and say for sure, okay, that's what's causing the pain. It really is more of a clinical diagnosis that we as practitioners have to make based upon your symptoms, based upon your presentation and your exam. And again, a lot of the pain symptoms that a patient with sacroiliac joint disease present with can overlap some of those other problems from the lumbar spine and hip. So it really can be tricky to differentiate. I remember very distinctly one of my first patients with SI joint dysfunction was a young man in New York, and he had undergone surgery to his lumbar spine about a year or so prior to seeing us in the office. He was in tears. He was just, not able to carry out any of his activities of daily living without pain. And he was young. He was in his 30s, and he was quite miserable. And he felt like no one really had heard his complaints all along. And, looking at his MRI from prior to surgery, he did have a very small little disc bulge there, but his complaints were really always sort of centered around the buttock area and the lower part of the spine just to the side. So when I examined him that day, I realized that I thought his symptoms seemed very consistent with sacroiliac joint disease. And we can say, with a great degree of relief now that, when we did ultimately wind up treating his SI joint several months later, he came back to the office. I mean, just an immense degree of gratitude, thanking us for figuring out what was wrong, because for all these years he had suffered. He had a surgery previously of his spine, but still he didn't feel like anyone was really hearing him. And this is really common with the SI joints. We see patients that are often frustrated for years because they don't really feel like anyone is actually listening to the complaints they present with. Okay. So as far as making a diagnosis of SI joint pathology or SIJ disease, again, unfortunately, we cannot do an X-ray or an MRI and say, here you go, we know what it is, it's the SI joint. So what we use as clinicians as our algorithm, number one, is going to be the history and symptom pattern. So can you localize your pain specifically to that point? If you look here in picture number one, you can see where this young lady is pointing her finger. That's usually the epicenter of pain for most patients who present with SI joint disease. And in the office, what we'll actually do, we can have the patient point to that area, or we know exactly where that little notch would be. We can push on that, and usually that's a major trigger for SI joint patients. We call this a Fortin finger test. The next thing that we'll do in the office to really assess that joint are what we call provocative maneuvers. So we have a series of 5 tests that we can do in the office that are very specific to the sacroiliac joint. And if we were to do, a full lumbar spine exam, hip exam, and incorporate in these provocative maneuvers, if they are positive, meaning if they trigger pain for you in that sacroiliac joint, gives us a really good idea that that may be the underlying problem. And we can say that with a good degree of what we call sensitivity and specificity if we have at least 3 of those provocative tests positive. The next step to confirm the diagnosis of sacroiliac joint disease is doing what we call an intra-articular injection or diagnostic block. And this can be a little bit confusing sometimes for patients. If you have ever been to pain management, you may have been offered epidural injections or medial branch blocks, radiofrequency. This injection is quite different. It's not meant to last for a very long period of time. It's really meant just to diagnose the pain. So it's a little bit of numbing medicine that would go directly onto the joint and hopefully numb up the joint. Now, in theory, if that joint is painful and you put some numbing medicine on it, like a Novocaine, something that you might have in a dentist's office, the pain should go away. And it won't go away forever, unfortunately. We wish we could say that it would. But again, it's really meant to just show us as clinicians that that is where the pain is coming from. And we can talk about this in a couple slides, but just to give you an overview. So we have the foot and finger test, patients' provocative exam maneuvers, and then the intra-articular block or SI joint injection after we've listened to the patient's history and symptom pattern. And again, so this is really describing the foot and finger test. And this is basically a patient pointing exactly to that epicenter of pain. In spinal anatomy terms, we'll say the PSIS or posterior superior iliac spine, big fancy word, but what it basically means is just over to the side of the spine at that lowest part. Sometimes people will say right where that little spinal dimple is on the lower part of the back, just above the butt. Now, the provocative maneuvers, like I said, these are very specific to the sacroiliac joint. And this is not something that every clinician will do in a typical lumbar spine exam. So it is important, if you feel like this is something that you might have, you really want to make sure that your clinician is doing a thorough exam to rule in or rule out the sacroiliac joint. So with these 5 exam maneuvers, it's not very important for you to know each one of these, but it is important to know that we have 5 very specific maneuvers that will help us really deduce whether or not the sacroiliac joint is what's playing a part. The most sensitive and specific out of these 3 exam maneuvers are distraction, thigh thrust, and compression. So these are techniques that your provider will be able to do in the office, again, to try to elicit that pain. Okay, now we spoke a little bit about the injection, but just to sort of go over it again, because it is really important to make sure that patients have a good expectation and understanding of what this injection is all about. If your healthcare practitioner suspects that you do have SI joint dysfunction based upon your history, your physical exam, the next step is to go ahead and get this diagnostic SI block. So this is similar to a diagnostic hip or a knee injection, and it does need to be done under X-ray or CT CAT scan guidance. The injection is meant just to numb the joint temporarily in hopes of decreasing the pain, even if it's only for a short period of time. So if a patient were to say that their pain before the block was an 8 out of 10, our hope is that within about an hour after the injection, that pain level, again, if it started up pretty high, 7, 8, 9, our hope is that after this injection, it will drop down. So we would like to see an injection provide relief of about a 2 out of 10, for example. And so another thing we like to do after this injection is have the patient go ahead and try to do some of those activities that were painful before. So if you had a hard time sitting for more than 5 minutes prior to the injection, you may want to try sitting after the injection, give it a little bit of time and say, I'm much more comfortable now. I couldn't do that before the injection. These are all really important things for you as a patient to document and for your clinician to document as well, so that we know whether or not this injection was helpful in reducing your pain. Again, it may not be very long term. Sometimes patients may say they've had, about 12 to 24 hours of pain relief following an injection. That's an ideal scenario, even if it's only a few hours of pain relief. To me, that would still be considered a positive injection, meaning a confirmatory injection. And on that note, so what do we, as clinicians, what do we actually consider a positive injection? So a patient having 50 to 75% of pain relief following the injection would be considered a positive block. And there are a couple reasons for why you may not have a positive block. So number one, obviously it could be that it just is not the sacroiliac joint causing your pain. And then that's where your clinician may want to revisit the lumbar spine or the hip as the origin. It could be that the injection was not properly placed in the sacroiliac joint, and that's why it really is so important that when you are being referred for this injection, that it is done under X-ray or CAT scan guidance. And usually what the injection professional will do is put a little bit of dye into that joint, or contrast as we call it, and this is an arthrogram. Basically, it shows us that the injection needle is actually placed directly into that joint. Another reason that a patient may not have a positive response could be that, you know, the pain returned. And so a patient thought, oh, well, it couldn't have been positive. It couldn't be a positive block because my pain is back already. And again, that's why it's really important to remember that it's not meant to be long-term pain relief. It's meant to be just a diagnostic block. Other diagnoses may exist in combination with the sacroiliac joint, and that's something that you know, a lot of clinicians may find in day-to-day practice. You know, a patient may actually have a lumbar spine problem in combination with the sacroiliac joint. So it's really important to have these conversations with your provider and try to really assess which problem is most symptomatic for you, so that we can go ahead and try to address that primarily. Okay, hopefully you're all still with me here. We're going to go ahead and ask another question now. So question number 3, have you tried to do something before about the pain? And you can go ahead and select all that apply here. So option 1 would be oral medication, physical therapy, chiropractic care, injections, lumbar fusion. Okay, so I'm going to give you all a moment here just to go ahead and complete this survey, and then we'll talk about the results.
This is great, Danielle. We'll give everyone just another minute.
Sure.
To be able to weigh all of their, sometimes it takes an extra moment just because people who have been in pain for more than 3 years have tried a number of things. So
More often than not, yes, unfortunately.
exactly. So Julie, will rely on you to indicate when people have finished. All right, and let's look at those results, if you can share them.
Okay.
All right, so
I'm happy to see physical therapy. That makes me really happy. I think, you know, physical therapy is just a wonderful resource to have, and it's important. I think in no matter what the underlying pathology is, whether it's the lumbar spine, the hip, the sacroiliac joint, physical therapy can really help a patient stabilize their spine better, you know, increase their ability to walk. You know, maybe there's some type of underlying gait issue or something that needs to be addressed. And physical therapists can be really wonderful at sort of targeting these issues and working with patients individually to come up with a good treatment plan for them. Oral medications, yeah, it's unfortunate. You know, we live in a time where you know, we have access to a lot of wonderful medications, and more often than not, non-steroidal anti-inflammatories, ibuprofen, Motrin, those can be really helpful, but obviously that's not something that we want our patients to be on for a very long period of time, certainly not at high doses anyway, because it can affect the body. Chiropractic care, injections. Oh, and I even see a few of you in there with lumbar fusion. Okay.
Right, perfect. So I think that this is a great segue as you've done such a good job of covering diagnosis and making sure that the right diagnosis leads to the right treatment. Now, if you could take us through some of these non-surgical management and transition into potentially surgical management when people have been properly diagnosed with SI joint concerns.
Absolutely. Yeah. So, you know, we do have quite a few non-operative options for you, obviously. So the SI belt, that's the one that we'll get into first here. So you may have seen this. It's different. It's not a lumbar belt. It is very specific to the sacroiliac joint, but I have to tell you, it takes a little getting used to. So you're basically wearing it directly over the belt line, and the goal is for it to really provide stability around that SI joint. And if it's worn properly, it really can provide some good relief. Females have a little bit of a harder time wearing this belt. It tends to sort of ride up a little bit, and it can be uncomfortable. You know, it can be tight around the clothing. So if you are able to try it, I certainly recommend it because it is a good option. And you know, interestingly, if you wear this SI belt and you say, oh my goodness, you know, this really helps me, that's even more of an indication to us as providers that that's actually the source of your pain. But again, you know, really depending on the degree of pain, whether or not this is something you want to try long term, obviously, again, it's a case by case scenario. So physical therapy, again, this is really important for those of you who may have sacroiliac joint dysfunction. And you really want to be sure that, when you are being referred to your physical therapist, that it's not just for, a generalized physical therapy session. This should really be targeted directly at the SI joint. And the goals of physical therapy in relation to SI joint dysfunction are core stability and core strengthening, because those core muscles in our abdomen and some muscles that kind of wrap around the side, the buttock area and the back of the spine, those really do help to stabilize that sacroiliac joint. And as we get older, it's normal to have some degeneration of those core muscles. So a good targeted program in PT will really help to address that. Okay, so like we said, physical therapy is sort of a mainstay for SI joint care. And then the injections. So we spoke about a diagnostic block, and I don't want to confuse you here. So by all means, if you have any questions on this, please feel free to, insert it into your Q&A and we can talk about it after. So if you've had a positive block and we know that the SI joint is what's causing your pain, by all means, you can then go to your pain management physician or a PM&R doctor or a PA or NP who's treating patients from a pain perspective, and you can have a therapeutic injection. And what that is basically very similar to the block, except they've added in some steroid. And the purpose of the steroid is to make that numbing agent last a little bit longer. So if you got 4 to 5 hours of pain relief after the diagnostic block, a therapeutic injection may help last quite a bit longer. So maybe a week or 2 weeks. Some people are fine doing therapeutic injections every now and then, but more often than not, we find that these don't typically tend to last for a very long period of time. And of course, we want to be very careful because steroids can be dangerous and actually can even promote bone degeneration even further. So usually there's a limit on how many of these injections you can do, especially if you've had any prior lumbar epidural injections or steroid injections in any other joint of the body. Now, RFA or radiofrequency, this is something that may be offered by a pain management physician, and it can be done for the spine. It can also be done for the sacroiliac joint. You may have heard of this as a simplicity procedure or something along those lines. And it's really very case dependent. Some patients find good relief with this, and certainly, prior to considering surgery, you may want to consider it. Studies have shown more recently that the overall benefits of RFA or radiofrequency, it's sort of a mixed result. Some people, like I said, find good results, but some people just don't really notice any significant relief. So it's up to you and it's up to your provider as to whether or not this is something that you may want to try. Okay. So once we've exhausted some of these conservative options, the SI belt, physical therapy, therapeutic injections, perhaps medications, we may want to start thinking about surgery as an option for some of our patients with SI joint disease. Back in the day, 100 years ago, sacroiliac joint surgery was there were no minimally invasive options. It was a big surgery, and so it tended to lose favor from a surgical perspective. It wasn't something that was very commonly performed. Since 2010, we have had a remarkable sort of a groundbreaking technology that's come out for the treatment of the SI joint, and we call this the iFuse implant system. And that's what we here at SI Bone really have prided ourselves in developing. And so what this implant system will do is help to stabilize the sacroiliac joint. It's minimally invasive. The incision is about the size of a quarter. So we say less than 3 centimeters. And so it's all done, in the operating suite. It can be done ambulatory. Most patients will go home the very same day. So it's a minimally invasive procedure. It's very well tolerated. And we'll go into a little bit about the actual procedure itself so you can take a look here. This is a little animated clip that I like to show that really kind of goes over the procedure here. So you can see there's the sacroiliac joint in yellow there. Those are ligaments covering on top of it. Okay, and you see how there's just a very gentle movement of that iliac crest there. So, and the sacrum, which is in the middle, that's stable. So these 3 implants here are the iFuse technology. And these we can put in again, we come in from the side of the body there and can place them under just using a tiny tube. We can insert them across that sacroiliac joint, and that will help to provide stability in that joint so that there isn't any increased motion. And this fusion occurs almost immediately because you're putting these 3 implants across that joint. So patients typically immediately after having this procedure will say, notice significant pain relief. There's always a little bit of incisional pain just from the actual procedure, but the joint itself is really fixed at that point, and the stability is there immediately. So what's interesting about the technology of this implant system, so it's a triangular shaped rod. It's really a remarkable technology, and we actually use 3D printing to make these implants. So there are all of these tiny little grooves and ridges, and that's what allows for your body's own natural bone to actually grow in and through these implants. So within about 3 months, your bone will completely take over this implant and solidify, even strengthening that SI joint further and further. Now, as far as the procedure goes, like I said, it's, typically it takes about 30 minutes to 1 hour in the operating room. Most patients are able to go home the same day. As far as the patient satisfaction, and this is what really hit home for me when we first started doing these in our practice back in New York, patients across the board, and we have numerous studies reflecting this, patients will say that they have about a 91% satisfaction rate, which if you ever have had a prior lumbar fusion surgery, you may know that it's really hard to have such high degree of satisfaction in any type of spinal surgery. So it's an incredibly rewarding thing as a practitioner to be able to see a patient come back after this surgery in tears of happiness, not pain, because they're having this relief that they just never knew was possible. So as far as our clinical data, and this is again something where SI-BONE really stands out among the rest here, we set out when we first started doing this study to document patient satisfaction over 2 years. So if you look at this little chart here, and it's a little tricky to see, I'm sorry, I hope you can follow along here. So the number 8 on the left side of that graph there, that's the initial pain complaint that patient would come in with. So patient says, oh, pain is 8 out of 10 pre-operatively. These are showing the patients who were operated on. So you can see immediately after surgery, that green line drops all the way down. So now patients post-operatively have a pain scale of about 2 out of 10. And that level stays the same not only for 2 years, which was the initial goal of our study, we actually extended that study out to 5 years. And we're showing that over 5 years, patients have prolonged, sustained pain relief, which is really just remarkable. And, to have 5-year data like this in the spinal technology sector is, it's really impressive. And I think it speaks for itself. So we see here again, VAS, which is what we call our pain scale. So again, 8 out of 10 preoperatively, and that's just an example. Everybody's a little bit different, but you can see that it drops significantly, where postoperatively you're looking at numbers about 2 out of 10, and that stays for a long period of time. Not only does pain improve, but so does disability. So patients find that they're able to get back to work, they're able to walk, they're able to sit, they're able to do all of those things that prior to surgery they were not able to do. Again, and this is basically just our 5-year extended data here. Okay, so before we wrap up and get into questions, one more question I have for you is, would you feel comfortable speaking to your provider over here, sorry about that, about the SI joint being the contributor to your pain now that you've listened to this talk today? Yes or no? So would you feel comfortable speaking to your provider about the SI joint being a potential contributor to your pain? We'll give you a minute to answer here. All right. All right.
All right.
Okay, that makes me happy. Okay.
Very good. Danielle, great presentation. And I think that number is a delight, certainly. We have a few questions that have come in. I know that we want to get to those but I'll give you just a minute if there were other points or you want to speak to the poll answers also.
No, I'm happy that I was able to provide a little bit of insight into the SI joint. My role now, although I am a clinician, because I have seen so many patients with this over the years, it sort of became a subspecialty in our neurosurgery practice. So for the past 6 years or so, I've been going out educating clinicians, providers on how to actually diagnose this and how to work it up. And so that really is my role now. I'm an educator to providers, teaching them about the whole process. But I love nothing more than talking to patients about this, because it's something that, again, we don't know about. So even if I was able to give you a little bit of information and familiarize you, with the SI joint, I hope that, you are confident enough now to go to your provider and say, I heard about this SI joint. There was this young woman talking about it. And, do you think this could be my problem? That makes me really happy. And whether it is or it isn't, I'm just glad to be able to educate you all today. And I hope that I was able to answer these questions for you. And just to sort of recap and summarize what we spoke about. So if you do have low back pain, don't be afraid to ask your provider if they've considered the SI joint as a possible cause. Again, not all practitioners are really skilled in picking this up and diagnosing it. But if they're not, maybe they can at least refer you to somebody who is, whether it be a surgeon or someone doing these injections, so that you at least know someone can evaluate you further for it. And if this is the source of pain, we do have, of course, many non-surgical options: the physical therapy, the belt, medications if you're able to tolerate them, possibly injections or RFA. And if those things aren't successful, there is this wonderful minimally invasive option for you. And we know that it's, across the board, it's very well tolerated by patients. And it's not a big lumbar fusion surgery. Anytime you say fusion, I know patients tend to get quite scared, especially those of you out there who have had lumbar fusions. This is very different. It's a minimally invasive procedure. Takes about 30 minutes, usually to an hour, can be done as an outpatient, and overall we see wonderful results. So let's go ahead and move in now to questions. Please feel free to ask your questions. And Nicole, if you have some of those, if you want to go ahead and start.
Perfect. I will jump right in here, and we'll take a few minutes. We have a woman who's with us who's asking if the tingling can go into the feet. She's got some pain, tingling in the buttocks, in both legs, pain in both feet, and especially under the heel.
Okay. So it can. That sounds like it could be an L5-S1 pathology, but I have seen patients with sacroiliac joint dysfunction that have had symptoms extending all the way down to the foot. Those initial diagrams that I showed were the most common presentations, but that's not to say that it isn't possible. And on that note, I'm glad that she brought that up, because sacroiliac joint dysfunction, again, we have two sacroiliac joints.
Right.
And it is possible to have SI joint disease of both sides. It is more commonly on one side, but I've treated plenty of patients over the years who have actually had what we call bilateral or both side SI joint disease. So it is possible. And I certainly would ask your provider to do some of those provocative maneuvers and consider an injection if it seemed like that was something that was consistent with your exam and your history. Definitely.
Absolutely. Another person is saying that in his case, his pain is limited to the lower back only. He's never had leg pain. So concerned, this sounds like it may not apply to him. Will you just quickly review differential diagnosis, where those overlapping pain patterns can come from?
Yeah, so absolutely. You do not have to have pain going into the legs, into the thighs, into the calves. Sometimes patients will come in just with that painful spot on their back. We have a definition of what we call axial back pain. So that would be pain that's really more centralized in the middle of the back. And that could be coming from lumbar stenosis or degenerative disc disease, anything of that nature, pars defect, or, issues with the actual spinal anatomy. So those issues of the lumbar spine tend to be more centralized and right in the middle.
Okay.
Sacroiliac joint disease tends to be just off to the side a little bit. So just to the side of the spine, but it can be, again, it can be centralized just to that area. So you do not need to necessarily have pain into the buttock or the leg to say that you have SI joint disease.
Okay. We have another gentleman who's saying his problem, he was told, was attributed to lumbar spinal degeneration, but all he's hearing here sounds more like SI describes his pain. Did he miss something in the presentation? How would you suggest he empowers himself to go forth and get a diagnosis that really keys in on his pain?
So it's a great question. And I think this is why so many patients with SI joint dysfunction are frustrated when they're coming to the office, because they may have had this diagnosis of, degenerative spinal disease for years. And so, there becomes a point, what do you do about that? Well, do you want to have a big spinal surgery, or do you want to just continue living on with it? When in fact, it's easy to just continue to attribute someone's pain to a degenerative spinal problem. But have you actually ruled out the SI joint? And that's something that a lot of clinicians may sometimes overlook. Again, my job is going out educating clinicians to really be skilled in looking for this, because it's easy to see a patient returning for a follow-up. Oh, patient has degenerative spine disease. No need to really look into this further. It's a common return diagnosis. But if they've not done a sacroiliac provocative test, the Fortin finger test, or really listened, you may want to go into your provider and say, listen, I think this may be what's going on here. Don't be afraid to do that. And if your provider isn't really, concerned that the SI joint is an issue and you still believe it is, then, you can speak to someone who is skilled in diagnosing sacroiliac joint disease. And I will say that SI Bone has a really great website, and I would encourage you to go onto the website. There's a plethora of information there. We have videos on patient presentation and all of those things, and providers that are specifically skilled in diagnosing this. So I'd encourage you, do your research and speak to as many people as you can about it. And if you really think this is something that could be affecting you, don't settle for anything less than what you deserve, and be an advocate for yourself and ask those questions. Even if someone has just chalked your diagnosis off to degenerative spine disease for years now, doesn't mean it's not there. So
absolutely. We have a couple of questions about injections that I want to make sure to get to, knowing that injections are really the gold standard for diagnosing SI and making sure that this isn't people have an SI joint.
Sure. The injections can be a little confusing.
So this woman is asking, how long does the relief last with an injection? And I know that can be a confusing point. Can you clarify that?
Of course, and absolutely good question. So the diagnostic block, again, there are several different injections. So just to clarify, if you think that there is a possibility of having sacroiliac joint dysfunction, your provider will send you, or the provider may actually do themselves, a sacroiliac diagnostic block. Again, it's done under CT or X-ray guidance. A little bit of dye is put into the joint itself to confirm that it's in the right location. And then from there, the anesthetic will kick in. So think about when you go to the dentist and you have to have, hopefully not a wisdom tooth, but say you have to have some dental work done, right? That Novocaine is not going to last for more than a few hours. It's a little uncomfortable and annoying for a few hours, but it's typically not longer than about 4 or 5 hours. And it can be the same with that diagnostic block. It doesn't have to be any longer than, a few hours to say that it's a positive block. Usually the pain relief will kick in within about 30 minutes to 1 hour. Sometimes patients may feel pain relief for a few days, a week. More often than not, it's really just that anesthetic phase or that numbing period. So, anywhere from 1 to 12 hours. So I wouldn't expect it to really last more than a few days. And that's still considered a positive block. If you have pain relief in that time period, that's considered a positive block, even if the pain returns later on. I hope I'm clear on that. If I'm not, please feel free to ask again in there.
Absolutely. So even if the pain goes away for a few hours after the injection, even if it returns, that is still considered a positive block and an
Correct.
indicator that SI may be a contributor to the pain. Is a contributor
Absolutely.
to the pain.
Correct. And it differs from therapeutic. Again, therapeutic is when we know that you have the diagnosis of SI joint dysfunction, that the therapeutic is when you add the steroid into it, and that may make the injection last a little bit longer. But the diagnostic block, again, don't expect more than a day or so relief from that.
Wonderful. Thank you so much.
Of
So
course.
another question is coming in about their pain management doctor said that the injection to treat SI is not advisable with her level of osteoporosis. Also that the chiropractic treatment not advisable. How can she know for sure that her pain is due to SI and what treatment is most advisable without seeing her? It's hard for you to answer that completely, but in that
I think I understand what she's asking there. And to be very clear, I think that the sacroiliac block, the diagnostic injection, is extremely low risk. It's essentially a small needle, and it's a very small amount of numbing medicine that's injected. It's not a steroid. The diagnostic block is just the numbing medicine. So the only reason that there may be a contraindication or a reason not to do this block is if a patient is on blood thinners. And even so, a blood thinner might have to be stopped for a day or so prior to the injection, but it's not to say that it cannot be done. So if it is something that you really do want to have investigated, don't be afraid to say, listen, I'm really concerned that this is what I have. I would like to just have the diagnostic block. There are other treatment options sometimes that pain management may be able to offer that are a little bit more invasive or aggressive. This is different. This is just a block. And certainly as far as contraindications go or reasons that you wouldn't be able to do it, the only acute reason that you wouldn't be able to have a block is if, again, you're on a blood thinner, and that, you can get around that by just stopping the blood thinner. You'd have to speak to your physician about this, of course, or your PA or your NP. Let them know that you're on a blood thinner. If that is, even the reason, it may not be here. Other than that, I don't know of any contraindications or reasons that you wouldn't be able to have this block done.
Okay. All right.
Yeah.
Fantastic. Thank you.
Mhm.
Got two more
Of course.
questions. I know we're getting close on time. This patient's asking about, can they diagnose the SI by pressing on that point that you spoke about in the back? Can you just review the Fortin finger point and
Sure.
the specificity of it?
Absolutely. So it's a great tool for you to be able to do at home. And unfortunately in COVID, we did a lot of appointments via telemedicine. And so one of the things that as practitioners, we would ask our patients to do, stand up, point to that spot on your back where it hurts the most. And if that little dimple there, just to the side of your spine, right above the buttock, if that is what's really painful, that's a great indication that you might have SI joint disease or dysfunction. And so I would certainly use that as a segue, when going back to your provider, say, listen, I think I have, and you can even be fancy and say, I think I have a Fortin finger test, a positive Fortin finger test.
Right.
And then what they could do is go ahead and do the provocative exam maneuvers as well as the injection. We can't say that a Fortin finger test in and of itself is a gold standard in the diagnosis. It works together with your symptoms, with your history, with the physical exam and the injection, but it's a really good indicator that it's probably the SI joint. So definitely something to speak to your doctor about or your PA or NP, if that is where it's painful.
Great. Thank you
Great
so
question.
much.
Sure.
Absolutely. And this next question is, how much does the iFuse procedure cost? Can you just speak in general terms about insurance coverage and
Sure.
cost for this procedure?
Of course. So most insurance companies do pay for this procedure. Of course, there may be some deductibles involved, but what's really great, again, SI Bone sort of leads the market as far as treatment options because we have actually what we call exclusive use. A lot of insurance companies know the benefits of this product, and so they will actually approve it, as long as everything seems like it's consistent with the diagnosis of SI joint disease. It's usually approved and covered completely by insurance. Of course, again, if there are deductibles or facility fees, things like that may be incurred, but the procedure, again, is usually always covered by insurance. And if it's an out-of-pocket thing, that would really have to be case to case, depending upon the insurance and the facility. But again, even in an ambulatory surgical setting, this can be done as well and covered by insurance.
Absolutely. And every payer will have different coverage policies, and those need to be
Definitely.
met. But, and a lot of times providers are well versed in mapping those out.
And what's most important, and sorry, I don't mean to cut you off there. What's
No,
most
no.
important in that is that, again, insurance companies, they want to make sure that your provider is doing the surgery that's most appropriate for you. So they just want to know that you actually have this diagnosis. And again, the way we do that is the exam, the symptoms, provocative maneuvers, and the injection. So as long as those things are there and consistent with SI joint disease, most insurance companies will send an approval for that and will cover it. Yeah.
Thank you so much.
Of course.
So I know we're approaching the top of the hour, and want to make sure that we have a few minutes to wrap up and just point you to the URL on your screen right now, which is if you are looking for an iFuse trained provider, like Danielle talked about, someone who is experienced in diagnosing and treating SI joint disease, then we'd like to direct you to si-bone.com, and we have a Find a Doctor feature on our website. You can find it on the homepage or at the Find a Doctor URL to be able to ask questions of an informed provider who's used to diagnosing and treating the SI joint.
Absolutely. And thank you all so much. I know an hour is quite a bit of time for everybody, especially during the work week, but I appreciate you all being here. And I really hope that I was able to give you some good insight and information. It's a wonderful option to be able to have to treat this really debilitating disorder. So again, I'm glad to be able to be here to educate you all, and I hope you all learned something from this.
Thank you so much, Danielle.
You're welcome, Nicole. Thank you, everybody.